Okay, it's time to start the live case session 2, SFA intervention. I'm going to chair this session. My name is Dr. Urasawa from Takehiro Memorial Hospital, Sapporo, Japan. And my co-chair is Dr. An and Professor An.
My name is Taehoon from Jae-Hwan Hospital.
So, we have many dedicated commentators on this session, so please come up to the stage.
Let's do a shot and see where we are.
Hello?
Okay.
Can you hear me?
Hi.
Hi.
Are we on?
Hi.
Hi.
Hi, Urasawa.
Hi.
Hello, everybody. Hi.
Please start.
I'm Rich Heuser. I'm here with Dr. Yu. Go ahead, and Dr. Yu will present the case.
Okay, I present today's case. A 56-year-old man was admitted for the treatment of left leg claudication, Rutherford 3. He already underwent stent implantation for the total occlusion of left SFA 7 years ago, and also underwent another stent implantation for the severe stenosis of left common iliac artery 4 months ago. The left ABI value was 0.83. He is a current smoker and has a medical history of diabetes, hypertension, and dyslipidemia. This is the demographic characteristics I already explained. And now he presented with the intermittent claudication of the left lower extremity. Echocardiogram showed the normal LV systolic function. CAG also normal finding. Thallium scan not done. So as I mentioned that, the ABI 0.96 and 0.83 for left leg. So next. So we're gonna show the peripheral angiogram for the left SFA lesion. Could you show me the?
Show us the first shot.
Yeah. 4 months ago, angio.
Oh, the old one? Okay.
4 months ago.
Oh, great.
Dr. Yu, what kind of stent did you implant before? The name of the stent.
The name of the stent.
Do we know what kind of stent?
We don't know. Could you talk about the
Smart stent.
Yeah, smart stent.
Yeah.
Yes. Smart stent 6 millimeter by 20, and smart stent 7 millimeter by 18 millimeter. Wow. 7 diameter. 2 stent. So 4 months ago, angiogram showed that the diffuse in-stent stenosis in stent stenosis, as you can see. But today, so we checked the peripheral angiogram, show that the total occlusion, as you can see.
Yeah.
Can you see?
Yes.
Show the total occlusion if we could.
Yes, we can see.
You're seeing that? So, we want to throw it back to the panel. What would you do? We're at a standstill. We don't know what to do.
Sure.
Should we send him for FemPop?
Let's discuss about this with
FemPop?
the discussant. So, Dr. Yokoi, what can I do for this type of re-occlusion? What device and
this type of the stent-free stenosis pattern is the very, very worst type, total occlusion type. So if open the balloon angioplasty, I think the refractory stenosis many times occurred. So I choose the drug-coating balloon or drug-eluting stent. 2 types of drug-elution devices I want to use.
Okay.
Okay, that sounds like a good approach. Does that mean, I guess we need to cross it then first. So we've, Dr. Yu, let's go on to the next shot. So we have a contralateral catheter in place. And we delineated where the origin of the total occlusion was, separating it out from the deep femoral artery. And go to the next slide, or to the next shot. And Dr. Yu skillfully passed a glide wire and a glide catheter. And we see this stent ends, in other words, the in-stent restenosis sort of ends at the stent. So we don't have an area that we have to treat outside the stent, if you will.
Mm-hmm. Rich, this is Lawrence Garcia. Was his symptoms acutely changed, or did they slowly progress? Anything that would suggest that this was thrombotic?
I don't know.
I don't know.
We don't know.
So, I have no informed about the patient's symptoms. Only patient complained of nowadays in terms of the claudication at the crescendo pattern.
But an aggressive change like this brings up a good point, Lawrence. And I'll tell you my prejudice, and this I want to hear what you think, Lawrence, about how you would treat this. We can treat this with simple balloon angioplasty and then a drug-eluting balloon or a drug-eluting stent. But the question is, would you do atherectomy ahead of time? And if you suggest that there might be thrombus, what kind of atherectomy? What's been proven to reduce restenosis?
Well, I think if you go back to the data...
For an in-stent restenosis.
Yeah, at least in the U.S., the data would suggest that laser as a primary therapy may have a better benefit. It's a low mark, though. I mean, their primary patency was still only in the 40s compared with the angioplasty alone arm. The reline or DCB market seems to be a fairly attractive market if you go down the road of an atheroablative technology. And the atheroablative technology seems to be useful, particularly if it's thrombotic, too, because it generally will get rid of the thrombus as well as the hyperplasia.
Right. I think both of those approaches would have been good. Probably, if I was doing this in my lab, I might have gone with a laser simply because it's simple, it's easy, and but you're already going to have a pretty expensive procedure already with a bunch of drug-eluting balloons or drug-eluting stents. So a case could be made to use a regular balloon and then, but again, from an economic standpoint, I think the outcomes will probably be about the same. So we went ahead and we ballooned it with a 7 millimeter by 200 balloon. And actually, we haven't seen the results yet. So let's do a shot here. Okay? You ready to go? Let's go ahead and do a shot here, okay? Come on down. Okay? That's on Cindy. Okay. Let's try to do that same shot with further down. You can pan it down a little bit. So the runoff is pretty good. We went in with a 7 millimeter balloon. Results look pretty good. I mean, the balloon was fully inflated. I guess the question is, should we go ahead with the drug-eluting balloon now, or should we hit it more aggressively? I don't know. I don't want to tear these things.
I think that usually after the conventional balloon angioplasty in stent restenosis lesion, late outcome usually poor, as you know that. Usually conventional balloon angioplasty result show that within 6 months, up to 70% of in-stent restenosis late, and then the clinical-driven TRR rate is also very high. So
I think we need to do something differently.
Yeah.
And so this might be a case that you would use. Some people like to reline it, as we mentioned, with a covered stent. What do you think about that, Lawrence, or the other panel members? Let's get the drug-eluting balloon.
Yeah, I think that you can always go down the road of a covered stent graft. I think that you could probably get away with allowing it to fail one more time before you go down that road, and just use the drug-coated balloon technology.
You're preaching to the choir.
Yeah.
Yeah, I'm very conservative on the covered stent. I feel that once I put the covered stent, then the only other option after that is FemPop. So and this gentleman, I don't think we need to go that route. I think the drug-eluting balloon to start with sounds good. So we're going to go with a Medtronic Impact. So we have a 600 by 120. So I think we're going to use probably 2 of those. I like this condom cover they have over it. We don't get that with the VAR device, and I'm afraid my sticky fingers sometimes touch those drugs. So this is nice. It's all yours. Okay, is it going in?
So, Dr. Garcia, I have a question for you.
Oh.
Dr. Garcia?
Yes.
Yeah.
Yes.
Over here. Okay. So, what do you think about the Rotolex atherectomy catheter? Is that available in the United States? Rotolex.
Rotorex, I don't know if it's available in the U.S. I've seen it. I have not used it personally.
Okay. Because I think this type of reocclusion in the stent always contains a lot of thrombotic materials, and as Dr. Heuser said, it's really important to think about the distal thrombosis during the procedure for this type of lesions.
Let's go up. Yep. I think these require a minute inflation time. Is that what they recommend? So let's do them for a minute. Is that what they recommend? Okay. So let's pan back here. I wonder how many we're going to need. I was thinking just 2, but I think we're going to need more than that. Pan back. Let me see the numbers. Pan back, please. Pan back. So I think we're going to need 3. Don't you think?
Yeah.
Don't you think? 6 by 120s. I don't think we're going to get it with 2.
20. Do you have 20짜리 있어요?
They're 6 by 120s.
We have no.
So, Dr. Inoue, do you use zero PDX stent for this type of lesion? Stent
I don't
reocclusion?
like, and stenting stent is not so good for this region. So, and I can personally import and put it back. So I have some experience, and the recurrent resistance rate is very low compared to the balangiopathy, and I prefer the drug in this situation. Yeah. Also, I want to more clean up and in the stent, so I want to use a laser catheter in this situation.
So let me ask you how to use a
clearly,
laser to
2
this
of
kind
these
of
are not
tough
gonna work. We can get that.
instant
That's all yours,
restenosis.
okay?
So you will use top tandem?
Yes, and initially I use the simple laser, then I use the tab tandem and more clean up.
What about the energy setting? Sure. The maximum?
Okay. Energy setting initially and default and start by default and 45 and
You mean 40
25,
by
25,
25?
and then
Okay.
and I going up to the
Up to 60, 40?
Yes, yes.
Okay, let's go with the second, please.
So, how many drug-coating balloons you need to cover entire regions?
I think we're going to need 3.
3? Okay. Well, Dr.
Yeah.
Heuser, the second cast drive is ready for broadcasting. Can I go to the
Why don't you
next
go there?
one? Is that okay?
Absolutely, no problem.
Okay,
For
let's
sure.
move to
We'll
the
see that.
next cast drive.
Yeah.
Not yet? I'm sorry. This cast drive is not ready, so you can keep on the procedure. Sorry about that.
You know something? I was already feeling lonely here already, so I'm glad you kept with us. So, we're just going along. I just want to thank SJ for inviting me. I just love working in the lab here. I always have so much fun. Everybody makes you feel at home. Mm-hmm. Let's see, we're pan back a little bit here. Do we have everything covered? I think we do. Everybody happy with going there? Mm-hmm. Yep. So we're going to put a third 6 by 120 up after this.
As they're doing this balloon, Sensei, if I could ask, the Leipzig experience, Sven, how would you guys treat this in your lab?
Sorry about that.
Yeah. Hello, this is Sven Braunlich from Leipzig, Germany. I mean, in this run now here, in this angiography, now you see very nicely the gap actually between the stand edge and then the balloon surface. This is actually indicating all that material that you actually want to get rid of the stand before ballooning. Because once the vessel is standard and you only
compress the material to the stent wall. So you lose a lot of lumen, and the smaller the final lumen is, the earlier the vessel can reocclude. That's why we always, for instant restenosis or instant reocclusion, use some kind of debulking to remove the occluding material before we apply truck eluting devices, whatever. Actually, in this case, if it's really chronic occlusion, which we can estimate from the duration of the symptoms of the patient, we can use with directional atherectomy like the TurboHawk device. If it's rather subacute or even fresh, we have big experience with the Rotarex actually, which is a rotational thrombectomy device, which also can remove more organized material, not calcium, but
we can take it out.
Neointimal material. And by doing that, so we can remove already before using any balloon, remove a lot of occluding material, and then we have a better, access of the truck from the balloon to the vessel wall actually, because not so much surrounding material which is still in there.
Yeah, I understand. I have a question for you. During the procedure using Rotarex, do you need a distal protection device?
Oh no, not. We don't use it because the aspirational strength of the Rotarex is so high that actually we don't experience any embolization during the Rotarex passage. Sometimes I use a filter after additional ballooning if I cannot remove all of the occluding material out of the vessel, and if there is then something suspicious, then for the balloon I use the filter.
And my understanding is that Rotarex is the rotational metal head combined with aspiration capabilities. And is there any trouble with the usage of the Rotarex in the instant occlusion because the metal was some interaction with the stent or strap or something?
Yeah, actually in the stent it's very safe because you cannot perforate. Only if you have really severe stent fractures where the struts look into the lumen, there you should be cautious and maybe cross this portion of the stent without activation of the device.
Okay, thank you very much.
So I'd like to ask you about scoring balloon. What about scoring balloon before DCB application? So in the coronary field, it has recently been suggested that pretreatment with scoring balloon may improve the clinical outcome of DCB for the treatment of DS instant restenosis. So I'd like to know how scoring balloon may work in a peripheral field.
Well, personally, I don't have a data, and also there seems to be no data with regard to the scoring balloon for instant reocclusion, but I guess the major problem is the length of the balloon.
Right,
only 4 centimeters is available in the Japanese EVD market. So if you have to treat the 30 centimeter instant occlusion, it's really time-consuming procedures.
We have a 200 millimeter scoring balloon available.
Really?
And I really appreciate the remarks from the Leipzig operator.
That's great.
In that, I agree with you. I'm a little hesitant here because I see that layer of intimal hyperplasia. Probably, maybe a scoring balloon would have taken care of that. Maybe a laser, maybe an atherectomy. I think these are all good points. And I think that another reason why hopefully the drug-eluting balloon will do it for this gentleman, but if he comes back, I think we need to really get it completely cleared up before we treat it again. But we've got what we have, and so we're going to take a look. We can deflate this.
Do you have any data about the kinds of strategy in restenosis? The debulking and then the drug-coating balloon strategy is superior to any other combination of therapy?
Personally, I have no idea. What do you think?
Theoretically, that strategy is very, very optimal. But however, we have no solid data, so that have to be proved.
Yeah, the problem is we just have the Excite trial that shows laser for in-stent restenosis is superior to balloon for in-stent restenosis. But of course, we combine these therapies, and that's the big $64,000 question. Is it better to use atherectomy and drug-eluting balloon, or is it better to use atherectomy, drug-eluting stent, et cetera? Let's take a look here. Okay.
Exit site.
Yeah, do you want to do a run-off? Yeah, let's do a
run-off.
run-off.
Run-off. Yeah, which
you have to tell me when you're ready.
It's a run-off.
Okay.
Because of
let's do it.
the embolization
Sure.
risk in this patient is
Tell me
very
when
high.
you're
So
you
we
ready?
have to. But,
Ready? You want,
wait.
a little more, guy.
I'm not familiar with this hospital's devices. Okay. Okay. Ready? Go.
Come on down.
More. 이거 돌려줘야지.
Are we going to go further down?
이거 돌려서 여기 디스타까지 갈 수 있게. 오케이. 여기까지 안 오나?
Well, I have to say that it's not the biggest SFA I've ever seen.
오케이, 자, 풋까지, 풋 서클까지.
But,
플로우 잠깐 드리네.
and it's not the prettiest picture, but it's what we have here.
이 나이트인가? 오케이.
Yeah, I think it's quite important because the angiogram showed the blood flow in the SFA area seems to be a little bit slower than the volitional one. Seems to be some kind of distal embolism.
Oh, let's see. We're going to start a little higher, or you want to start a little higher? Or are you just going to go here? Just going to go here?
Yeah, okay.
Okay.
A little bit higher. Okay. That's it.
Do it.
Okay. Go. Go. This time?
Yeah, looks okay.
Hey, runoff looks pretty good. I think we're okay.
Good. Congratulations.
Okay. It's very good.
Thank you. I think we're in good shape on this.
I think that this case is too easy for Dr. Heuser.
This is a challenge enough.
Thank you. Thank you very much. It's nice.
Thank you.
It's great.
Thank you.
Thank you.
Appreciate it. Okay, good job, everybody.
So let's move to the next room.
Okay.
Okay, Dr. Bersin?
Introductions.
Dr.
Yeah,
Bersin.
hi, good afternoon.
Hi, good afternoon. You're on the screen.
Good afternoon. So we have an interesting case for you. We've done a number of CTOs across the day here. This is a 54-year-old with intermittent claudication, although it's severe. It's Rutherford 3 to 4. His right ankle brachial index is 0.4. And I don't know if we can show the CT angiogram, if that can be pulled up. That suggested a long segment total occlusion of the right SFA. So we did a diagnostic angiogram. It would be nice to see the CT if that can be shown. But if you're seeing the angiogram currently, you can see it's occluded proximally at the origin of the SFA. Reconstitutes quite a bit distally, just at the adductor canal. So I don't know if they can see the CT angiogram or not.
Please show the CT angiogram.
There you go. Can you see the CT?
Yep, we can see.
Okay, perfect. So this is a classic TAS D long segment total occlusion. Relatively younger patient, so not heavily calcified. So let's walk you through what we've done so far. If we can go back to the fluoro cine playback. Can you see the contralateral guide injection?
Yes.
Okay, so you can see there's just a proximal stump of maybe 1 centimeter at the most. Go on to the next. And this is now with the contralateral Ansel guide sheath in place. A little better imaging of that if you go to the next. So all we did was take down an angled CXI and a V18 wire, and here I am working through this. There's a couple of sections where we had some resistance, but it passed through reasonably quickly. Okay, go to the next. And here we are doing a guide injection to try to find the distal landing zone, and you'll see it appear here. It's really a nice large distal vessel. Okay, go to the next. So we kept at it actually with the V18 and because we were making good progress. And you'll see us redirect a couple times. I think we found a side branch once or twice. And then here we are at the distal cap. And just go on to the next, if you will. So in brief, we were able to cross just with this equipment. You can see the V18 is now downstream. All right, and go on to the next. All right, so here's our distal injection. The wire's headed down. If you go to the next. So we do a distal injection, which was a little distal into a geniculate, so we pulled back slightly. And here we are. So we're across the lesion. Let's go ahead and now have the Grand Slam wire. Oh, fine. Yeah, we have just a supportive guide wire. So we're across the occlusion. Now it's open for discussion what to do with it. So I'll open it to the panel.
Okay, so the guide wire already passed through the CT lesion, type the lesion. What should we do next? The balancoplasty and the stenting, or DB or DS? So what do you think about Dr. Yamashita?
In Japan, actually, just balloon and stent. So SMART, Misago, or Zilva PTX. That's it. We have no good debulking device in Japan, right? So just balloon and stent.
Well, okay, the operator's here. We've been working away, so we haven't really discussed how to finish. I would agree that probably stenting's a good idea for long-term patency. So we'll exchange out the CXI, and then we can discuss. I think we balloon first, see how it looks, and then decide, huh? So do we have a... what's our longest 014-based balloon? 014, 018. Just go ahead and prepare like a 4 millimeter diameter. Long, I would say a long 4 millimeter. Okay, so we're nicely down the distal vessel. It's a big vessel.
Yeah.
Seems unusual.
So we're going to pre-dilate this.
It seems a little unusual that he has a really nice profunda and his ABI was 0.4 with an SFA occlusion. It just seems a little unusual, but I think balloon stent makes sense. The alternatives would be, it looks like he crossed pretty cleanly. Yeah, you could just get away with balloon alone, i.e. DCB. As alternatives, but I think if you want to get the rail down there, it probably makes good sense. I mean, you're at what, 25 centimeters, Bob, or a little bit longer?
Yeah, I think so. Our ruler there, our reconstitution is probably
40,
at 40 thereabouts, yeah. And we start at about 10. So yeah, 30 cm. Let's use this 330 cm. That's good. Let's use that. Mm-hmm. So we have it's a little smaller diameter, but we have a 30 centimeter length balloon. So that'll be ideal. It's a 3.0. That's enough just to predilate, I think, to see what we have.
Okay.
The audience...
CT CT image shows that there is some calcification at the mid and the distal portion of the SFA. Did you have any trouble to advance the guide wire in that region?
Yeah, I went over it fairly quickly, but I think you saw in one of the fluoro playbacks that the wire was hung up there in the mid. I think that was at the area of calcification. So I just kept at it, and it found a way. The V18 wire is really quite good at navigating that, but I think you're right. I think there's a couple areas that are fairly hard, but on a relative scale compared to the other cases we've seen today, it's relatively modest. So I think we have all options, I would say. So pan up a little higher. There we go.
Dr. Garcia,
Tight.
is this a good candidate for Viabahn?
Well, I think
I think so.
Yeah,
I think it would be.
I think going to the data, it probably makes sense. You know, they're the longest to date right
go
now.
to the lower end.
And it's a CTO. I mean, they were 6 out of 10 CTO. So I think if you really fell back and onto that data set, you'd be fine using a covered stent. I think first line therapy out of the box, I probably wouldn't do it. But from a data set, I think that's fine.
So we're inflating this long 3.0. It's 30 centimeters long, so I'll pan up so you can see the length of it. If you haven't noticed, we did something unique today. Instead of leaning over the table, we reversed the patient. So we're working left-handed with the patient flipped.
We've gotten very used to standing on the left and working left-handed for folks.
That should be all the way up to the origin, so that's good. So it looks like the lesion's no more than 30 centimeters. Okay, you can come down. So this would suggest, and I believe this was the case, that I was subintimal at times, and then I re-entered right at the distal cap. Maybe I'm true lumen all the way, but I doubt it. I would vote to stent this in some form or fashion.
Yeah.
Everyone agree?
Well, so what do you think of Dr. Do you put the stent in this case?
Yeah, but
it looks disrupted already.
You have two options. You have a larger balloon and the coated balloon. Yes, your strategy. Another thing is after larger balloon and the stenting technique. Was I prefer the spot stenting instead of the full long stent. So people then I use the IVUS study to see the what's happening on the lumen and see some calcium location and some see the some first lumen. If this is I think it is to consider before some next strategy.
Well, but in this case, just the 3 mm long balloon they used, but we need a little bit more bigger balloon before deciding what should we do next.
Okay, you want to balloon it a little larger? That's fine. Now, one consideration is we don't have a filter to protect this, and this is a thrombotic occlusion. By dilating more, we could get emboli. But I'm okay with that. I'm okay with ballooning it some more. Originally, I asked for a 4 millimeter. This was a 3, not very large. We can go higher. Do we have a 5.0 300? First 3.0, the biggest. Oh yeah. Okay, we'll use that. So we have a 220. 5.0 by 220. We'll use that.
Great.
So Bob, if this doesn't look any better, what's your choice of stent going to be?
Well, yes. So Ideally, I would use PTX Silver or Viabon because this is a 30-plus centimeter occlusion. I mean, it's a TAS D. I showed the data on that earlier this morning. It's clearly better than bare metal, I think, in the long lesions. Now, that being said, that's an expensive approach. It's a big vessel, which is in its favor. Runoff is also good.
Yeah.
So it's about 37 or so, yeah. Okay. Go on. So again, this is a 5.0 by 220. Take it up gradually. Tell the patient you may feel a little discomfort. Okay, store monitor that. Yeah, the patient's feeling that one a little bit. I think that's a fold in the balloon rather than a lesion. A twist, yes. I think so. So why don't we deflate, and we can, why don't you deflate, and then we can reinflate. Yeah, a little further. Okay. All right, let's go again. Go gradual. Interesting how the wrap, there it goes.
Okay.
All right, that's good. Store monitor that. And then we'll do one more inflation at the origin. It's a big vessel. According to the guide shot, I would say it's at least a 6.
Yes.
Although he felt the 5-millimeter balloon. Okay, I think you can come down and we can go to the top. Yeah. Tell him sorry. Should get better. It'll get better. A little medication. Okay, you can go up again. Gradual. Okay, store that. Well, so what kind of stents do you want to do? That's okay. We can change more. But what stents would you like? What are the choices? Well, we'll see. We'll take a picture. There you go. Okay, coming down. Well, let's take a picture and decide. Hold this sheet, if you would. Go ahead, you finish. Now, a little dissection up top. It looks pretty good in the middle.
Yes.
So now let's go in the AP view. That was in an oblique. And then we'll just do a run all the way down. You'll follow me down. Let me get into position here. Back up. Okay, ready?
Yeah, looks pretty good.
Looks pretty good.
Yep.
Well, I think we're done. No.
So
the
this be
origin
a
clearly
good case
needs-
for DCB and so-called spot standing, maybe only
Yes,
proximal?
I would agree.
Yeah.
Yes. I think that changes the game, huh? Do we have 6 millimeter DCBs?
Or do you want to make another oblique of the SFA, maybe from another angle that looks
Yeah, sure, certainly.
more severe disease? No? Or this dissected?
Careful there.
The recently I always use 2 different sizes of wrong balloon for SFA CTO, long CTO cases. You know, the balloon size step up, started at 3 millimeter diameter and go up to a 5 or 6 millimeter. So by
Okay,
using
this is
that,
an ipsilateral oblique.
yeah,
Follow? Oh, sorry. Miscommunication, my fault.
no, it's okay. So after using 2 different
Okay.
balloon sizes, the result is remarkably improved.
Okay, follow it down now.
So like these cases, you can finish just the balloon alone, even in advanced CTO cases.
I think there's a little dissection mid too, but it's really not flow limiting. You see that in the mid vessel?
Yep. Definitely you need a stand for proximal portion, right?
I would agree. The rest of it, though, I think we can just do prolonged balloon inflations.
Yeah.
And now the question is he felt the 5 millimeter balloon? Maybe we should stay with 5 for the DCB?
A little bit bigger size.
Or a low pressure 6, I would say. Yeah, let's use that. Okay, we have to change the wire. So we just need a diagnostic catheter. So I would think he's so symptomatic and has such a low ABI because it's a recent thrombosis and he has not developed robust collaterals, would be my guess. Profunda is wide open, but as you can see, there's not that many communications between the profunda and the SFA. There's one distally, but it's not very robust.
This collateral had a stenosis as well, right? That one that went back to the SFA.
I didn't think so initially. It might be some balloon-induced spasm or something. Just no, non-hydrophilic. Just a regular, like extra support wire. You have like a. Yeah, that's good. We're just changing out from the 014 wire to an 035 to facilitate delivery of the DCBs.
Dr. Urasawa?
Yes.
So in previous session, the DCB efficacy is reduced in calcified regions. So do you consider this point in your real practice when you use the DCB?
Well, in Japan, the DCB is still on the clinical trial, so we cannot use that devices for regular practice. So I don't have any idea for that questions.
So in this case, in CT angiogram, there is a heavily calcified region within the distal part SFA. So,
How's he doing? All right? Oh, not much longer. A few minutes, 10 minutes. So we have the impact 6x120. It's being loaded. I'm going to go back to the AP view since that brings the ruler back into view. point of reconstitution was about at 37.
Dr. Bersin, I am Yokoi from Japan. We have, in Japan,
Yes.
the drug coating balloon is not available still now. So very limited experience in Japan. So please tell me the technique of the DCB. My question to you, this case is CTO, that Dr. Heuser's case is ISR. That depend on the region, you usually change the inflation time and the inflation pressure as a technical point. Similar pressure or similar inflation time?
Yeah, so you want to do a good full pre-dilation. You want the DCB to be your last dilation, preferably. And the inflation times, it's better for drug transfer if you go a little longer, longer being at least 90 seconds, preferably 2 to 3 minutes.
Mm-hmm.
And we try not to, hold or scrape the material. Now, loading this is a little bit of a challenge here because it's a Ansel with a valve rather than a TUI. So there it goes. Hopefully it won't scrape too much. Yeah. Okay. You can continue. And then once you've fully pre-dilated the lesion, you don't need to do a high-pressure dilation with the DCB. You want to just maintain good contact. It's bring the tip down to 37. A little more.
Yeah, it's very important
good.
that the DCB get good contact with the vessel wall. That's why it's
So you just go gradual,
actually also okay to oversize the balloon a little bit.
not too fast.
We noticed from the Levant 2 trial, the subgroup with a slightly oversized balloon had much better outcome in terms of patency.
Go slow. Yeah, so we're going to, no more than 6. The patient's feeling it already. And remember, this is a 6 millimeter. The pre-deal was a 5. Come down a little. So you can hear he's feeling it. So I've backed down to 4 atmospheres. And the timer is on, yes. So it's a little boring here while we do this, but there is belief that drug transfer is improved by more prolonged balloon inflations.
What about the post-procedure antiplatelet regimen? DAPT, how long?
So DAPT is really only required for those who get stents. Minimum of a month generally is recommended, especially if you have any dissection. This one's going to get a spot bare metal stent, so it's a minimum of 30 days. So we're almost at a minute and a half. And notice we went up as high as 28, so. Okay, you can come down. Yeah, same. Okay, hold. We'll need at least one more of this length, and then the third one might be shorter. It's not fully deflated suction. Use a syringe.
Bob, what are you going to spot stent on this one?
Yeah, I think so. The origin needs it for sure.
Yeah. So
We'll look and see if any other segment needs it.
So if your second balloon gets close, would you just do a DES proximally? I mean, it's going to be expensive no matter what, but what's your thought on the origin?
That's a good point. I think that's a good point. Do we have paclitaxel PTX? I mean, it's probably cost effective. I don't know what the cost differentials are here. We have it? I think that's a good idea, Lawrence. What about this? Yeah. Yeah. Okay, this is the second 6x120. You have wire? Let's remember to 28. That's pretty good there. Okay, go up gradually to 4 again. The vessel might be a little larger up here. He's feeling it. Yeah, he's feeling it pretty significantly. So we're going to stay at 4 atmospheres.
So, Dr. Bersin, could you tell me the reason you exchanged the guide wire from 014 to 035?
Well, it just makes it easier to deliver. These are 035 balloons, and you know, I think we would just struggle more. In the interest of time, we just did that, so it'd be much more efficient to deliver.
Okay.
And then especially if we're going to do a silver PTX at the origin, it's really helpful to have an 035 wire. Now, as far as length of what's left, it's not that long, maybe a 60. Is there a 6x60 silver PTX? Don't open it, just locate it. Since you don't have a headset, for your benefit, they suggested doing a silver PTX instead of DCB in a bare metal stent. Makes sense. Okay, down, that's a minute 30. So I think in the interest of time, what we'll do is take a picture, because we know we have to stent the origin for sure. The question is whether anything else is needed for the DCB treatment segments.
Yes, please.
As I see, there's only about, 8-9 minutes remaining. Okay, you want to follow me down? Ready? Okay, go.
Oh.
Pretty good for the most part. There's that one section in the middle where we struggled a bit with crossing. Let's see if I can freeze on it. Right up in there. Lumen's pretty good, though. What's the vote?
So, what do you think? So, everybody wants to talk.
Well, it's a tough call, huh? This is...
I mean, this is an area that was treated with the DCB, so, and it's a longitudinal dissection that not affects the blood flow. So I would actually leave it, because we've learned that after DCB, these longitudinal dissections can heal.
I was tending to think the same thing because flow is so good. And it looks more adventitial than luminal. I think we put in the spot stent at the origin and then look at it one more time.
Okay.
6 by...
60 is double below.
You have 80?
760 or double. You get 40.
Oh, too short.
100. What 100?
I think we can use the 7 by 60, yeah. Okay, we're looking at our assortment of what we have in terms of silver PTX. And they don't have a 6 by 60, but they have a 7 by 60, and we used a 6 millimeter balloon, so I think that's okay. Might be slightly oversized.
So zero PTX stent has a relatively weak radial force compared to the others, so I think one size bigger might be better. So the 7 mm is the best fit for this case, I think.
I think you're right. So I'm going to take a magnified shot of the ostium here so we can land this correctly. It's a lot of saline, so let's do it one more time. So we don't have the benefit of overlay, but we can see it's where it is, and we have a roadmap. Fortunately, it's not a narrow angle bifurcation. Okay, we'll go ahead and load the stent. Oh, yeah, they do have overlay. Okay, great. So what I suggest is you go a little beyond and then pull it back. Keep going. You're not there yet. You'll see it. Okay, go a little beyond. Yeah, go a little further. A little further. Now pull it back. Right around there. So when I'm doing the osteal bifurcation, I don't really focus on the distal aspect of the stent at all. It's solely on the proximal end. And this one's a little tricky in the sense that we're doing this upside down and backwards, so the sheath makes a U-turn, which creates some slack, but I think it's easily controlled here.
Great.
Perfect. Okay. Okay, off overlay, and let's go ahead and post-dilate.
So, 1 minute left.
No, 6. Just the 6. One of the 6 balloons we already had is fine. A DCB balloon or...
DCB balloon 아까 6 있잖아.
DCB balloon would be ideal. Yeah, you have 2 of them. Just go ahead and load that up quickly, because they only have about a minute to go.
Bob, you made the stent delivery or release look easy. I think that the release mechanism on Zilver PTX is incredibly hard. Are any tips or tricks to deploying it so that you can hit that origin pretty well?
Yeah, it is hard. The first trick is to just release the initial friction and get the stent to the end of the delivery system. And then you take your time after that. This one was not as hard. For some reason, it was reasonable. Okay, up we go, just like 4, 6. Because the balloon is longer than the stent. And 6, I think it's okay. Good. Okay, store that image. And down. And we can post-dilate some more if need be, but I'll just take this out to give you a picture because it's right before closing time.
Sounds great.
Okay, we'll take this out. Go ahead and finish it up. Is this contrast? Okay, ready? It's okay, stop there. There's a lot of saline again. And then now you can follow me down. The origin looks great, huh?
It looks great.
You hit it very nicely.
Okay, we'll start from the top of the stent. You can just come down a little. Come down a little more. We'll start right around here. Okay, ready to follow? Okay, go.
Yeah, still looks great.
You want one more of the distal? We'll get you one more of the distal. It went off the screen there. And let's, yeah, that's good there. And we can demagnify one. Okay, you don't have to pan. We'll just see it come down here. Looks pretty good.
Great. Congratulations.
I don't know, my vote would be that we're done.
So just in time. So it's great to see your procedures. Thank you very much.
Thank you.
So I think it's time to close this session. Thank you very much, everybody, and thank you very much, audiences. Thank you.